Are you guys seeing ADD/ADHD in children and young adults update?
I need to edit that. It's not, I must have really had my finger on the button.
No, that's how it came to us.
I know, I must have.
Yes. I'm thinking she combined ADD and HD when she did it, but that's how it was.
All right, I will edit that.
I'll edit it. What, you want it to be
no, it just needs to be ADHD, and I'll edit it, or you can edit
I'll
it.
edit it.
Okay.
On the thing.
All right, ADHD. Notice that it's a lecture all by itself. Now, Dr. Sal, who I've worked with for the last 6 years, is a local, pretty much a local expertise in ADHD, but she has since retired, and she has allowed me to use her PowerPoint. That's the reason her name is still on it. However, I have taken it and twisted it, not twisted it, but edited it. Okay. So we are going to, I give her credit because she's the one who originally put it together, but, and she's great at ADHD. She's taught me a lot, but all right, moving on. Let's talk about the numbers. This may be a little bit different in your book, but it's not going to be too far. 3 to 8% of all school-age children have ADHD, and it's going to be more likely in boys than in girls. It's, as she says, it's the most commonly studied diagnosed psychiatric disorder in children. It's very chronic. I am 57 years old and I'm on ADHD meds. I admit that. Right here, it says 30 to 50% are still having issues in young adults, in young adulthood. Well, evidently I had issues for a long time, and it's only been in the last 4 or 5 years that I got somebody to listen to me, because in my age group, there was no such thing as ADHD. And then I got to be an adult. Oh, there's no such thing as adult ADHD. I finally got somebody to listen to me, and it has made such a difference in my life, being able to focus my thoughts, not interrupt people in a conversation that I'm not supposed to be involved in. It has made me much more socially aware. It's helped me to stay focused in my job. I'm much better about not forgetting things and staying organized. It has been such a blessing that I get a little freaky when I get down to very few pills left. So now that sounds like an addict. I'm sorry, it's not. It just that it's made that much of a difference in my own personal life. Now, 75% have some genetic factor, and if I look at my own life, I can identify those genetic factors. And then I look at my own 28-year-old, who was the one with the concussion. He's there as well. So I get it. We see a lot of kids with this. The specific cause is really unknown. We've got lots of factors that contribute or even exacerbate ADHD. There is a huge genetic component. Usually if one of the parents has it, then that parent is not surprised when the child is diagnosed with it. There are other environmental factors that can help with that, or maybe even some causes. Lead exposure, anything that's going to be toxic to the fetus, alcohol, smoking, prematurity, any infections, and then of course organophosphate insecticides. I have to be really careful with that one. But also artificial food colors. Go figure. Who would have ever thought that anything unnatural might cause harm to a fetus? Of course, sometimes you're going to see issues with ADHD after kids have had a traumatic brain injury. I have permission to talk about a child that had a really severe sledding accident a couple of years ago and hit a pole sideways, just slammed into it. They were being pulled around on a sled. So major traumatic brain injury, had never had problems with ADHD prior to that. That is now on ADHD meds. So if a mom has depression symptoms during pregnancy, they have found that there's a link there. Also the chronic use of Tylenol or acetaminophen during pregnancy. Now there are also several studies showing specific increase in ADD prevalence and severity when mom smokes, but also the increase with dad smoking also. So I've always accused my older brother of having ADHD, and he used cigarettes, which is a stimulant, to calm him and as his medication. So it doesn't surprise me that studies have shown that parents who smoke, their children are more likely to have ADHD. It makes sense to me. I think that's more of the genetic factor than anything, but that's just me. All right, so on table 30.5 on page 433, the DSM-5 list for diagnosis of ADHD. It is a neurobehavioral disorder. It can be listed or diagnosed in 3 different forms. We can have the attention impulsivity. We can have the hyperkinetic. So we've got our busy versus our lack of focus, and then, or they call it inattentive or hyperactive. And then there's the combo type. There's a large aspect of both inattentive and hyperactive. Usually symptoms have started before age 7, but it may not be diagnosed till much later. And again, those are our 3 types. Usually 5-year-old boys and up are usually on the hyperactive side. The classic female is usually your inattentive, and 65 to 70% of the children are combined. So we have, again, screening tools that helps us make the diagnosis of ADHD. Why can't we just look at them and say, oh, they're hyper? Because sometimes it's just the kid being a normal kid. And we have to distinguish that this parent and this child may not be suited as far as their style of what they are. In other words, this kid may just be a regular active rambunctious kid, and this parent wants a calm, quiet child, and they're just not well suited for each other, but the child may not be hyperactive. So we have 2 rating scales. One is the Connors and the other one is the Vanderbilt. My favorite is the Vanderbilt, and you have that, don't you, in your packet of stuff. And there is a parent version and the teacher version, and you want each parent to fill it out, and you want each teacher, if they've got more than one, to fill it out, and you want to review all of that before you bring the child in for evaluation. There needs to be documentation of having issues in more than one location. If it's an issue at home, but it's not an issue at school, then we need to look at what's going on at home. And why does that parent think that this kid has ADHD? Are they just trying, we have to look at that. If mom and dad are okay with it at home, but the teacher is just worn out with them at school, is it a teacher-student fit issue? Is there a learning disability that hasn't been diagnosed? So it's really important that we look at all the aspects before we just slap a label on it. Okay, that's where our screening tools come in very handy. With the Vanderbilt, you can distinguish between inattentive, hyperactive, depression, ODD, and ODD, oppositional defiant. I don't know if OCD is part of that. I have to look, but out of the 41 questions, we can look at different things and see, well, they've answered or they've graded high in this area, but really low over here. So this doesn't appear to be an issue either. Oh, they've graded high for hyperactivity. Oh, they've also graded for high for oppositional defiant. Do we need to be looking at something else? So the Vanderbilt distinguishes that, whereas the Connors does not. That's the reason I like the Vanderbilt better. The Vanderbilt also has a form, and I don't know if Dr. Blankenship has this in her packet of stuff or not, is a quarterly follow-up that the teachers can fill out and the parents can fill out. It's not as long as the regular one. One of our providers in town is OCD about making sure that the parents and teachers have filled out the follow-up for each quarter before she'll see them back for their, or get their meds. So that's continued documentation. And that's, you've got to have that. If you're going to continue a child on a Schedule II medicine, you've got to have continued documentation of some type that there still is a need for this medication. So they've got to be seen. So some of your other differential diagnosis may be acute anxiety, some petit mal seizures. Maybe this kid's not focusing because they are having, or absence seizures, because they're having seizure disorder that's just not showing up as a tonic-clonic kind of thing. And that hasn't ever been diagnosed. Some of these kids have, because of chronic otitis media, have hearing loss. They may have a learning disability, as we talked about earlier, and they're acting out, or they're not wanting to do their work, or they're causing disruption in school because they can't get it. They just don't get it. Depression, we talked about those kinds of symptoms. Sleep deprivation, electronics in the bedroom should be a no-no, and I have that conversation at least 10 times a day. These kids need to put the electronics away. They don't need to be in their bedroom. They need to go to sleep and not be disturbed by people texting them at all hours of the night, or playing Fortnite into the wee hours of the morning, and then expected to get up and function at school. Child abuse is often a comorbid condition. I'm sorry, that's child abuse. I've got stuff on the screen that's blocking me. I apologize. Depression and learning disabilities are very often comorbid conditions with ADHD. So, but child abuse can be another differential diagnosis of what's going on. So what are some of our treatment options? Who's going to see these? Primary care physicians should be willing to see these and evaluate these kids. We really only need to refer those kids who have lots of comorbidity and need more polypharm or psychopharm than we feel comfortable doing and managing some of those other kinds of things. And in Kentucky, this is not going to be on your national test because we're one of the only states that don't do this. Unless you're a psych mental health nurse practitioner, you cannot prescribe ADHD meds. I cannot prescribe ADHD meds, but I see a lot of ADHD and I do a lot of ADHD follow-up. My doc does the meds. And we coordinate together with that. Would I have been able to do that 5 years ago? I would not have felt comfortable doing that 5 years ago, but I've done enough training that I do feel much more comfortable with that. And my doc trusts me to help make those decisions. And if I'm going to start a kid, if I've got a kid coming in, we have a discussion about it. We look at the Connors or the Vanderbilts together, and we talk about what we think is going to be first line help for them and how we're going to start them. In the mainstream, 95% of the kids are going to respond to medication, and you're going to see a significant change in behaviors. If you've got a kid that's got, and most of the time in our adolescent and older childhood group, medication is going to be what you're going to do. Very few in our younger kids, they probably need behavior management and counseling and therapy. One of the biggest issues that we need to do with these kids, and they need to have structure. Kids thrive on structure. I think we said that before back when we talked about developmental milestones. The more structure they have at school, the more structure they have at home, the better life is going to be for them. No treatment can be an option. Some will try diets. A lot of people are very opposed to using stimulant medications or putting a kid on a Schedule II med. And I get that as a parent. It scared me, and mine ended up on an SNRI because we didn't have all the wonderful options when my child was little that we do now, or the efficacy and the changes in the formulations. So it's much better now than it was even 20 years ago. So, but diet can be one of those things. So part of what we do is that we need to teach parents and kids how to cope with their ADHD. And that includes our daily schedules. And if they're coming home and they're doing homework, then distractions need to be kept at a minimum. So where are they going to sit down and do homework that they're not going to be distracted by TV or other people playing or mom fixing dinner or other stuff going on? You need rewarding of positive behavior is going to be key while we ignore attention-seeking behavior. Okay, set small goals. Oh my gosh, it's going to be very important for those parents. You can't, how do you eat an elephant one bite at a time? But people with ADHD can't even comprehend taking the first bite. They need small goals, and that may just be getting through day one, day at a time. It's really important that parents help children stay on task, not nag them, but keep them focused and then limit their choices. ADHD people I can't go into a huge department store because I immediately am overwhelmed by all the choices. I do well if I go to a clothing store, I have very limited choices. That's better for me. And I didn't realize that was part of my ADHD until the last few years. Kids with ADHD, they really need to find activities where they can succeed. A lot of times they don't do well on team sports where everybody has to work together because ADHD kids don't always work well together in groups, but they do well with the team concept. So sports where they're competing against themselves or against another person, but they're part of the overall team, do really well. So like swimming, karate, martial arts is great for ADHD kids because it teaches self-discipline, but it also competitive, but part of a team. Gymnastics, tennis, golf, those kinds of things. They do better with those kinds of sports and activities versus a baseball or a basketball or a football or a soccer where they have to work together as a group and be part of the whole group to be successful. Families need to be calm and consistent, and everything needs to be predictable and immediate. So some of the things that we encounter, and I've talked about this already, is that they're afraid that if they put a kid on a stimulant, a Schedule II, that it's going to cause an addiction. Well, the interesting thing is that the data actually shows that kids that are treated for their ADHD with a stimulant medication actually have a much lower rate of substance abuse as an adult. It's because they're taking care, they're not trying to self-medicate is what they're doing. They're also concerned about cardiac issues. You've got old school that says they don't need medication, they just need discipline. And I think this was a lot of the feeling of when I was a kid, that it was just kids with behavior problems. A lot of parents are concerned about that black box warning. These medicines are expensive. So if your insurance doesn't cover them, it can range anywhere from $150 to $400 a month for ADHD medicines. And if that's the case, these parents are not going to take them. They're not going to purchase them because, would you? It's not like it's life-threatening. So they're not going to do it. They worry about diet. They want to do homeopathic things. Well, let's try this before we move on to that, before we try medicines. So you listen and you work with the family. A lot of times, if they're coming back in, it's like, well, how's this working? Well, we're not seeing any improvement. How's our school performance? Well, it can continue to go down. And then you eventually have to have that conversation. So at what point are you ready to try this? Do you want your child to be successful? Do you want to hold them back because they're not being successful in school? So some of those are the hard conversations to have. Usually as far as the comorbidities, 35% will usually have some other degree of mental health issues. Anxiety, anywhere from just mild anxiety all the way to panic attacks, depression, OCD, conduct disorder, we've already talked about, oppositional defiant, bipolar, learning disorders, very much comorbidities with ADD or ADHD. So let's talk about the different meds. Methylphenidate, and Dr. Shaw had written its cousins because we have different formulations of it. Methylphenidate is our generic. We have immediate release methylphenidate and we have extended release. So our most common type that we see and give out today of our extended release is the Concerta brand. It's an extended release formulation that works over time. It's a slower release. And it's well tolerated. The Focalin XR is dexmethylphenidate. It's a cousin. On that sheet, just the single Word document sheet that Dr. Sal had, that's on it's in your queue of stuff. Focalin, she lists that it's much more well tolerated and has less of a side effect profile. So if you can get insurance to pay for it, Focalin XR works really well. Now, due to either insurance or a failure of methylphenidate, and sometimes age, we're going to start an amphetamine. That sounds really scary to start a child on an amphetamine. And of course, its cousins, which is our mixed amphetamine salts. Our most common amphetamine is Adderall. That's branded, but that's the easiest way to talk about this particular medication. We have Adderall immediate release, and when I talk about immediate release means it's going to start immediately, and we're going to within 30 minutes, and it's going to be through the system, have its half-life, and within usually 4 hours, 4 to 6 hours at the longest. When we talk about an XR or an ER, we're talking about a medication that's going to go 8 to 10 hours, depending on the formulation. So Adderall XR is going to be extended release. It's supposed to cover most of your school day. And then lisdexamphetamine is Vyvanse. Now, Vyvanse is an isopolymer of amphetamine. The wonderful thing about it is it has less potential for abuse because it breaks down in second pass liver breakdown. So you don't have as much potential for yes, I'll get it in a second, for abuse. Because yes, these are all stimulants, but the wonderful thing about the way they work is in that people with ADHD, it actually has a calming effect. If people are abusing them that don't have ADHD, they're taking them for the high that they get. So these are our two main categories of ADHD medicines. Now we have non-stimulants, and one is selective serotonin reuptake inhibitor, SSRI. That's selective was the word I couldn't figure out. So we have selective norepinephrine reuptake inhibitors, and if you've heard of Strattera, that's that word. I can never say it. Strattera, we used a lot several years ago. You as a nurse practitioner who's not a psych nurse practitioner can prescribe Strattera, and it has to be slow dosed and worked up. All of these do. Strattera has a lot of issues with side effects. We don't use it as much because we just don't see the effective response as we do with the stimulant medications. You also have two alpha-2 agonists. Intuniv is the brand name, but it's guanfacine extended. We have both immediate release and extended release guanfacine and Capvay or Clonidine. Now, if any of you are RNs that work with adult patients, you're used to Clonidine being a blood pressure medication. Is that correct? So I've done kids for so long. My dad was recently put on Clonidine, and I was like, wait a minute, that's not for blood pressure. And I had to not say that out loud, or I'd have really showed my ignorance. We use it in kids as a secondary use with ADHD because of sleep. We give it at night for kids who are having sleep issues due to ADHD. So, and you can go up to 0.4 milligrams of clonidine. I don't have kids on that high. That's a pretty intense dose. But a lot of kids on 0.1 and 0.2 milligrams of clonidine every night before they go to bed to help them get to sleep. It's not so much once they get to sleep, it's winding down, turning their brain off so they can get to sleep. And that's part of the whole ADHD profile, is that the brain just never shuts down. Okay. And by the point that they get ready to go to bed, the ADHD medicine has worn off. So we've got to have something else. Guanfacine is very good as an adjunct, helping with other issues with ADHD to make life better. These three on this page are the only three that are approved for use for ADHD besides the stimulant medications. Combination therapy. We've talked about how important this is if you've got a stimulant plus a non-stimulant. We talked about the stimulant plus either the SNRI or the alpha-2 agonist. Sometimes we'll use a long-acting and a short-acting. Let's say we're doing great through the school day, but we've got sports or we've got dance and we've got other things in the afternoon. We may need just a little bit more medicine on board to get us through those activities. So at that point, we're going to use a short-acting stimulant. Cognitive behavioral therapy is important in especially our younger kids. A stimulant plus an SSRI like sertraline or Lexapro or fluoxetine can also be very helpful, because remember, one of the comorbidities is depression, anxiety. So a lot of times our kids that are on ADHD meds are also on an SSRI. So what are we looking for? When I've got a kid who's come in for their 3-month recheck, I am looking, and when these are the things that you're going to talk about parents with the parents. Are they? They're going to have anorexia. It really decreases the appetite, especially at lunchtime. So one of the things you're going to tell your parents is that they need to make sure and eat something. Now, but they eat their breakfast at school. They need something on their belly before they take that pill in the morning, before they walk out the door, because once that medicine has taken effect, they may not be hungry. So we need to get food in them, because we're going to watch weight. If kids start losing weight, or if they're not gaining appropriately as they gain height, then there have been times that we have threatened to take kids off of their ADHD medicines if they didn't increase their weight, just because it affects the appetite so much. And usually by the time they get home, but mom says, they never eat anything at school, but they get home and they're ravenous and they eat from the time they walk in the door until they go to bed, but he doesn't ever seem to gain any weight. That's okay. That's okay. Let them eat. If they are that, if they are have that much problems with anorexia during the day, and they're not like getting overweight and they're maintaining, or they're gaining as appropriately, then let them eat in the evening. There have been some kids I've looked at mom and said, okay, do you like milkshakes? And he'll say, yeah. Or she'll say, yeah. And it's like, okay, you get to have a milkshake every evening. Let's put some fruit in it, and let's put some extra ice cream in. And mom looks at me and it's like, no, we got to get some calories, or we're going to have to stop our meds. And the meds are improving their life so much that they'll do whatever we need to maintain the weight, to make sure that we move on. We talked about the insomnia, that the brain just won't slow down. Sometimes that's where we have to use the clonidine. Sometimes these medicine will cause stomach aches, and I really think that's because they don't want to eat with them. Headaches can be an issue, so you're going to monitor that very carefully. Also, tics. If you see an increase in issues with headaches or an increase in tics, then you need to back the medicine off, especially if you're increasing in increments, then it needs to be, that can be a sign that we're having significant side effects. Okay. Now, growth disturbance, that's been an issue. People worry about that's going to make them shorter. 0.5 centimeters difference in kids over 6 years. 0.5 centimeters. That is 5 millimeters. Right? That's nothing. Now, cost of treatment, as we talked about earlier, can be significant. Some of that's pretty tame compared to one drug. And sometimes we have to play with the pharmacy. It's very frustrating. This is going to work. We think this is going to work best. And we send it through, and then insurance says, oh, sorry, we're not going to approve that. You've got to do this. And you put that one through that they said. And then it's like, oh, nope, sorry, we're not going to approve that. So it becomes a nightmare from a pharmacy and perspective, playing the pharmacy game. Or the kid's been on it for a long time, and the parent changes insurance or changes jobs, and we have a new insurance. So the new insurance, because it's a chronic condition, they won't pay for it either until they've gone through that insurance company's protocol. Yet this patient's been on it and doing well, and they're not looking at the overall picture. It's very frustrating. So as we talked about, environmental factors, structure. Assignment notebooks really help, making sure that they've got a list of everything that they need to keep up with. Bedtime and getting up time. Bedtime routines are very important. We need to be consistent with that. Take the electronics out of the room. Medication has to be every day, or at least every school day. Some of our kids will take the breaks off the weekend. And we need to take it at a consistent time every day. If they can swallow a pill, that's great. But we do have sprinkle, and we have liquid. Now we have a liquid methylphenidate, and we have oral dissolving tablets, and we have a chewable, both Vyvanse and a methylphenidate, which is great. Other options, the sprinkle is in the Adderall only. So there you go. I'm just going to kind of flip through this. You can go back and look at this, and this is how you start it. This is your Focalin. This is your dexmethylphenidate. We're going to start with 5, maybe, depending on how old they are. We're going to titrate and go up. We want to see how they're doing on it. Go low, start low and go slow. We talked, I think I have maybe issues that when I was playing around with this, I'm sorry. It looks like I got a couple of slides the same. Let me get through that. Oh, maybe it helps if I'm going backwards. Sorry. I am. Okay, so we talked about dexmethylphenidate, methylphenidate or Concerta. It's a swallow. We start at 18 milligrams and we go up. Less likely for diversion. And then, as we talked about, methylphenidate liquid is called Quilivant. That's the brand name. It's the first long-acting liquid that we've had. I have been on Quilivant. It's okay. It doesn't taste bad. I feel blessed that I can look at the kids. Oh, it doesn't taste bad. This has blah, 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 blah. Methylphenidate chewables, Quilachew. I've been on that too. Again, it doesn't have a very bad taste. Methylphenidate also has a patch. Now, that can be very good for our college students if they will use it correctly. But again, they've got to be compliant. So you can start at a 10 and go up to a 20, but it can be really expensive as well. Now, this is our Adderall. XR, like I said, that's the only one that you can open up and sprinkle. And then the less dexamphetamine is Vyvanse. It's usually a 12-hour duration, sometimes longer. The carrier mechanism, which I can't see the bottom of that. Hold on just a second. Oh, yes, the carrier mechanism is different. And this is one of the ones that is really hard to abuse. Evico is an amphetamine sulfate tablet. It's one of the cousins. There's less appetite suppression, more cardiovascular effects though. So you have to be really careful with that. I don't know if I don't have any patients on Evico. Or do I have any patients on Medeas? A lot of times it's because insurance won't pay for this. It's a triple beaded delivery system, and it's got 16-hour coverage, which is great for your older patients that are like working and going to college and that need that 16 hours of coverage, although it can have significant side effects with both sleeping and appetite. Danaval is an oral suspension. That's the Adderall oral. And then Adhd is the oral dissolving tablet. Now, our non-stimulant, Strattera, supposedly has 24-hour coverage. It does work well for some, but the big disadvantage is that it may be 4 to 6 weeks before you see any effects. So they may be on it a month, and it's really hard for a parent and a child to be compliant if it's going to be 4 to 6 weeks before they see any improvement. Sometimes we'll have used that in combination or in families where we don't need to have stimulants in the house due to a previous history of substance abuse.